Good evening, and welcome to this special edition of Doctors on Call on the COVID-19 pandemic. I'm Dr. Paula Termuhlen, the Regional Campus Dean at the University of Minnesota Medical School Duluth Campus, and I am your host for tonight's program. We're continuing this series of special programs to answer viewer questions about the coronavirus, and I want to thank everyone because you've been sending them in all week, so we're already set to go, and we look forward to having more tonight. This week, Minnesota Governor Tim Walz extended the emergency declaration until May 13th, although our stay-at-home order still runs through May 3rd, as health experts continue to monitor the pandemic curve. So there's a lot going on and still a lot of uncertainty. Our show this week will share the latest information to help keep you and your family safe. The telephone numbers and email address for your questions can be found at the bottom of your screen. Our panelists tonight are Dr. Chris Delp, an emergency room physician at St. Luke's Hospital, and Ms. Amy Westbrook, who is St. Louis County's Public Health Division Director. Members of the WDSC staff are standing by to take your calls and additional emails, and I want to thank them for helping to keep us safe. As you'll see us practicing social distancing, and everyone in the studio, fewer than 10, have masks, and everything's been sanitized, so we feel very safe here. So let's go ahead and begin with questions that have come in via email this week. So, Dr. Delp, you and I were talking a little bit ahead of time about this one, and I think it's really important that people hear about it. So, lots of conversations going on right now about virtual visits, this idea of maybe you could get your doctor online either by phone or via the computer, but is it still okay to go to the hospital, and is it safe?
So the virtual visits certainly have a role, but there are times when you still need a practicing physician to visit with you. And I think we've been doing so good at flattening the curves, maybe a little bit too good. Some people are delaying care when they really shouldn't. Now, the ER is an incredibly safe place. We're doing a very good job at sterilizing the emergency departments, and we are open for business. And if you think that you are having an emergency, don't hesitate. This is a very clean department, and we have doctors on staff all the time waiting to take care of people.
Great. So you fall down, you hurt yourself, you have chest pain, all those things, right?
That is correct. There's a lot of people that are Googling treatments at home instead of coming into the emergency department, and I'd certainly discourage that. I think coming in and seeing us is the best answer. All
right, very good. Well, so Ms. Westbrook, we also have a few questions going on. There's a lot of conversation about when are we going to be able to get back to sort of normal routine. And part of that has to do with something that's coming up a lot in the press right now around identifying the contacts of people who have been infected with COVID-19. Mm-hmm. So can you tell us a little bit about what is contact tracing, and how do we conduct those investigations, and what role might that play in sort of getting us back to normal?
Sure. Well, we do contact tracing in the public health system for a lot of infectious diseases, and it's something that we do with COVID-19 right now as well. Anytime anyone has a laboratory confirmed test, it's reported to the public health system, our Minnesota Department of Health, and those results we get as well as the lab and physician. The physician notifies the patient, and then we have the results as well. The Minnesota Department of Health follows up with everyone who has a laboratory confirmed positive test and asks about close contacts, so the people who are most at risk of exposure. So typically it's household contacts, it can be friends that you spend a lot of significant time with, or co-workers that you're in direct face-to-face contact with. That's not as common now because we're doing a good job with social distancing and staying at home. So often it's household contacts. And then those people, we also ask for them to stay in quarantine. So we ask individuals to stay in isolation who are symptomatic and are sick. And then we ask their contacts to stay in quarantine. So we ask them to monitor their symptoms for 14 days, which is an incubation period for COVID-19. So from the point of your last potential exposure, 14 days out, if you don't develop symptoms but within that 14 days, then you're in the clear. And so those people are followed up on a regular basis to see how their health is. Are they developing any symptoms? Are they staying in compliance with isolation and quarantine? So contact tracing is really the method of identifying close contacts who can be at risk and letting them know that they are at risk and so should be monitoring their symptoms and then should also be staying isolated or quarantined as much as possible.
So there's a couple of terms that you were using, and we had another question that just sort of wanted some basic understanding around it. So you talked about isolation. So isolation is really for the person who we believe has the illness, correct? Mm-hmm. Meaning they shouldn't be around anyone. And I know the CDC website has a lot of good information too about how to do that in your household. Now quarantine's a little different.
Mm-hmm. Yeah, so isolation is if you're sick, and you're staying away from people because you have symptoms and you don't want to spread anything to anybody. Isolation for COVID-19 is we ask people to stay isolated from 7 days after symptom onset or 72 hours until fever resolves without fever-reducing medication, whichever is longer. So 7 days or 72 hours after fever resolves. And then quarantine is a longer period because it's a full incubation period for COVID-19. So the incubation period is either, it ranges from 2 days to 14 days. So someone who is exposed maybe will start developing symptoms at 2 days, but can develop symptoms up to 14 days after that exposure. So we really want people to stay in place, away from people, for that full 14 days if they've had close contact with anyone confirmed.
And so then when we start talking about lockdown and stay at home, and that's really what we're all doing. We're the healthy people, we don't have known contacts, and we're practicing just the good guidance around maintaining a 6-foot distance, wearing a mask in public right now, and things like that.
Right, so yeah, isolation and quarantine is a public health strategy that's very targeted, and then we all are asked to do our part in staying at home and maintaining the physical distancing and separating ourselves. But it is different than isolation and quarantine because that is specific to a time frame and then specific to a certain disease.
Great. So here's a question that I think either one of you will throw out there, and it's one I think on a lot of people's minds. Is there any reason to believe that the warm weather will make the virus go away? I mean, typically influenza tends to die down in the summer. What have we been hearing about that?
Go ahead.
So if you look, I think, historically, trying to make the comparisons between influenza and coronavirus, I think it's difficult. We're seeing some of the most rapid growth in Florida. And Florida at this time is still very, very warm. And so like a lot of our data, it's lacking, but if you look at it where it is growing fast, it's still growing fast in the warm weather. Do you have anything more to add to that? Because I think the lack of information, we have a lot of information, but there's still a lot of gaps in our knowledge.
Yeah, I would agree. Respiratory illnesses typically do sort of wane during the summer months, but we just don't know how this virus really acts, and whether it would we would see less disease in the summer and then an increase in the winter. I just don't think we know yet.
Yeah. Again, lots of uncertainty. Dr. Delp, I'm going to throw this one at you. What's the difference between a respirator and a ventilator?
Well, let's start with their similarities. They're both in short supply.
Okay.
So the respirator is one of the most protective devices for a healthcare worker to wear. and that is what the emergency physicians and anesthesiologists that are doing airway procedures and our respiratory therapists, when we're at highest risk for getting the disease during these high-risk procedures, we wear a respirator that filters out. It's even more effective than an N95. And so the respirator is for the healthcare provider. The ventilator is what we've also been in short supply, and that's the mechanical device that actually helps people breathe. As we all know, this is a respiratory virus, and it hits the lungs very hard, and we see people whose oxygen levels are dropping to very dangerously low levels, and the only real therapy, we start with oxygen, the least invasive, but when that fails, then these patients need to be put on a ventilator with a tube down in their windpipe and having this machine breathe for them.
You know, one thing I saw in the news this week, in just helping everyone learn a little bit about the anatomy and physiology of our lungs, is that they've started to put some of the patients on their bellies to help them breathe better. And I know we were taught in medical school the idea that, you know, your air space is in your lungs, really trying to capture all that extra space, and that the position can make a difference.
It's very interesting. One of the more prominent emergency physicians in terms of airway, Dr. Levitan, who is volunteering his time in New York City, was asked, what that you know now do you wish you would have known a month ago? And he said that putting people in that prone position and not intubating them is for as long as possible, because it goes against our natural tendency. As soon as the oxygen levels drop, put the people on ventilators. So it's contrary to our typical standard treatment. And putting these people and proning them, you can see a remarkable difference. Even in the emergency department, we will take people and we can tell an almost immediate difference in their oxygen levels by doing that.
Yeah, something as simple as just repositioning someone. We had a writer write in this week. First of all, there's a lot of guidance right now around wearing masks in public, and I think there's a little bit of confusion around it, and most people aren't used to wearing masks. But this writer wants to know if you can heat the cloth mask in an oven at 170 degrees for 30 minutes, and would that be effective in sterilizing it? And we had an interesting conversation ahead of time. Talk to us about it.
So the only thing that I can really speak to in terms of research that goes from the emergency medicine standpoint is there was a discussion about physicians, especially emergency physicians, wearing ties. And there was a concern raised about whether or not you could get staph, the germ staph, on your tie and transmit it from patient to patient. And so they did a research study in which they microwaved those ties and found that you could eliminate the staph germs by microwaving your tie if you were really dedicated and wearing that tie. We do know that the coronavirus is heat sensitive. And so the primary function of the masks that people are wearing out in public is to prevent you from giving it to other people. And so there's not as big of a need to make that particular mask sterile. Would you agree?
Yeah, I would say the the homemade masks are more for source control than getting sick or getting the
sick yourself,
infection.
Right.
Yeah.
So here's one that I'm delighted to see because I had it in my pile from earlier and it came up again tonight, which is, why does the Minnesota Department of Health only give us information by county rather than city?
Yeah, we've gotten this question a lot.
I bet.
Because we are a very large county. St. Louis County goes all the way from Duluth up to Ely, so very large, and Virginia, Hibbing, and everything in between is part of our county. And so we are the largest county as well in Minnesota. We report all diseases across Minnesota per county. So that's how we do all of our diseases, because the county is the public health jurisdiction. So we do it by county. We have talked about, whether we want to be more specific. We've had conversations with the Minnesota Department of Health about, can we say Duluth, not Duluth? And we've sort of agreed that we would just stick with county, mainly because that's how we report diseases. We have seen COVID-19 reported within the rural and urban parts of our county. So that gives you a little indication that it's not just centrally located in Duluth specifically. But part of our reason for wanting to stick with county is because we don't want to give people a false sense of security. So if we had all of our cases reported in one of our cities, then would people in our jurisdiction in St. Louis County act differently than people knowing that cases are reported, an hour away versus in their own community? So we want the message to be, act as if any of the cases are, next door to you or in your community, because that's how we want you to act, and we want to assume that it is everywhere. Testing is so limited, so we don't have a good sense of community transmission. We know that we have community transmission. We've seen in the cases that we have that there's no known exposure, so we don't know where they got it, so we assume that it's circulating in the community. And so we want people to understand that that's true for all of the cities in St. Louis County. And there's a lot of counties that are much smaller than ours. So it is kind of a big deal for us. Not a big deal, but it does make sense for smaller counties to be reporting by county. But for us, a lot of people get frustrated that we report just by county and not say which city it's in.
Yeah, and the flip side to that is where the Minnesota Department of Health is now listing group facilities that have outbreaks. Mm-hmm. So it's almost on the other end of the scale, if you will, is now they're getting very specific around that. And I think probably the question on many people's minds is like, well, I really want to apply this to me, but we know that a lot of this is really about the population, really thinking about large groups of people and really trying to make statements and understanding what's going to happen with this virus, which leads me to my next question. Can you get coronavirus more than once? What do we know about that? Go ahead.
All right. So the first reports of coronavirus, people getting coronavirus more than once, came out of China. And the data on that was somewhat suspect because we weren't confident in their testing. And so that data was questioned over and over again. And now with the antibody tests becoming available, I think that question becomes even more relevant, because if you do have antibodies against this, is it truly protective, or can you get it again, whether now or a year from now? And so all of this information is still being processed. And I think the problem is we're practicing medicine unlike we've ever practiced before, which has always been studied, and we have peer review. And we've always practiced medicine in a very rigidly tested way. And now we're trying to adapt so fast and to process data so fast before it's ever been really reviewed and studied. I'm getting emails from colleagues that are on the forefront of from New York and from university systems that are trying unproven treatments because there's so much that we don't know. And I think the getting coronavirus again falls in that category on not enough to know.
And it's a little bit of that balance of risk. Right, so that we're really pushing forward so quickly. We don't want to cause harm inadvertently. But then there's things like, as we talked about earlier, the positioning of a patient where relatively simple seems to make a quick improvement, minimal risk of harm, let's do it. I know there's a question that's actually a very valid question that came in this week that had to do with wanting to know sort of a detailed timeline around vaccine creation. And I've heard some experts talk about how it will take at least a year to 18 months before we can get close to a vaccine, and part of that is just simply the testing phase. And are there ways of shortening that timeline, and what does it take to do it? And so we often say we're in these unprecedented times, and we really are, because we don't know how quickly to move to make sure that we're not causing harm at the time we're still trying to help. Mm-hmm. It's a difficult conundrum. So one of the things that, sort of on the theme of the illness and its cyclical nature, we've been hearing a little bit about when will we peak? When will we peak? And at one point we heard April, then we were hearing May, now we're hearing June and July. Or can we really predict that? Do we know?
Yeah, that's a good question. There are a few different models out there. I think it's really hard to predict. We're doing a good job at social distancing or physical distancing and staying at home. I think those are really, those actions that we're all doing as a community are making a difference. So it's hard to really know. Our case numbers, we continue to see rise. We continue to see community transmission. But I think we're doing a good job at flattening the curve. So I don't know. I have a hard time with predictive models. Our jurisdiction is a mix of urban and rural, so I think that can make a difference too.
Yeah, at the university, we've got several of the models they've been working with the Minnesota Department of Health, particularly there in the Twin Cities, and really our folks are saying you can predict about 2 weeks out right now, and that gives you the most accurate information. And beyond that, the error bars, as we say, really start to get much greater. So. Mm-hmm. We're actually very quickly going to be running out of time, and I wanted to make sure we got to this particular question because it's very local. Is there any thought that individuals who might have been exposed to the Husky explosion that we had, a little over a year ago, or about a little over a year ago, do they have any greater susceptibility to COVID? What do we think?
So I think I can answer a little bit of that because the people that were exposed that already had chronic lung problems, of course, after that explosion became much more symptomatic. And so those people that were most symptomatic after that explosion are just going to be more susceptible in general. And now looking at the amount of damage that occurred to people that didn't have any intrinsic lung disease, I don't think that there was a lot of people who suddenly developed severe lung disease after that in talking with my colleagues. We did see some of the people in the emergency department, but they seemed to bounce back without any permanent damage, at least in the people that I know.
Okay. So we're going to do a couple of rapid fires here as we start to wind down. COVID-19, what does the 19 stand for? Do we know?
The year that it was discovered.
The year it was discovered. Mm-hmm. All right. Here's one. A writer put in this week that they'd heard of a couple of cases of COVID-19 that they were diagnosed, but they never had fever. So how reliable is the temperature testing? Because I know that I'm getting checked as soon as I walk in the hospital, and I'm sure you are too.
So it's not like everything in regarding to COVID, it's not reliable. Some of the symptoms are just diarrhea. Some of the symptoms are completely absent of fever. And I've seen studies that range between 5 to 20% have no fever whatsoever during their illness.
But that's 5 to 25%, so hopefully we're capturing 75%, right?
Yeah.
Okay. A writer put in that in Shanghai they were testing the use of vitamin C. And in New York City, there's about 700 patients that are being trialed on using vitamin C as a treatment. We didn't really get to treatments much here tonight. Can or should we be doing this in Minnesota?
So vitamin C has been used in an IV form for people with overwhelming infections. We do IV vitamin C and septic shock. And so to think that this may apply to these viral infections, certainly the work that Linus Pauling did in the past, if you did have a vitamin C deficit, it definitely improved your immune system to take vitamin C to overcome that deficit and make you healthier.
All right. If you have a home testing device for your oxygen level, is that a good thing?
It is. It is in several different ways. Oftentimes we're sending people home who do have COVID or who we suspect have COVID. So the question is, when do they come back? Because they already know that they're sick. And a home testing device is just one more piece of information that we can give to them to tell them when to come back.
All right. What should people do with their used masks?
Their used masks, like homemade masks, or
I didn't specify.
Well, you could reuse your homemade masks. If you're in a healthcare setting, it's a little bit different. But us in our regular home environment, use your homemade masks if you're going outside.
And I know we're actually using UV light at the hospitals now to sterilize them. So we are at the end of our half an hour. So I want to thank our panelists, Dr. Chris Delp and Amy Westbrook, and our phone staff and crew for being here this evening. Please join me again next week when our guests will be Dr. Ryan Harden from the Gateway Family Health Clinic in Sandstone and Greg Ruberg, President and CEO of Lakeview Hospital in Two Harbors, where we'll talk a little bit more about the rural experience of COVID-19. Thank you for watching and have a healthy week.